So let's talk about the immune system. Since the immune system is a smaller body system, I have talked about the anatomy, the diagnostics, illnesses, and medications all in this one PowerPoint instead of having them separated. Okay, so when we're thinking about the immune response, there's a lot that, of course, takes place in order to create that immune response. And it has a lot of factors that go into it. Some of those are T and B lymphocytes. So the T and B lymphocytes, they are both necessary for a normal immune response to occur. These lymphocytes are produced in the bone marrow. They then migrate into the lymphoid tissue, where they remain dormant, and they're either used for cellular or humoral immunity. When we're thinking about the immune system, of course, it maintains and protects the body from external organisms and bacteria. The main function of the immune system is to protect the body from outside organisms that don't belong. So, when we're thinking about the humoral response is immediate. So, it provides protection against acute, rapidly developing bacterial or viral infections, as opposed to the cellular response, which is delayed. So, that humoral response is immediate, the cellular response is delayed. It's also called delayed hypersensitivity. You'll hear it referred to as delayed hypersensitivity if you look at other sources. It provides protection against slowly developing bacterial infections and is often involved in autoimmune responses. In addition to the humoral response and the cellular response, in regards to immunity, you also have innate and acquired immunity. So, innate versus acquired immunity. Innate immunity is present at birth. This includes your physical and mechanical barriers of defense. So, examples are your cough reflex, your gag reflex, your skin. Whereas acquired immunity is received passively through the mother's antibodies and antibodies produced in response to a disease or immunizations. So you have your humoral response, which is immediate, your cellular response, which is delayed. You have innate immunity, which is present at birth. And then you have your acquired immunity, which is received passively. Okay, so getting into diagnostics, there is a lab known as an anti-nuclear antibody or an ANA lab. It is often used in the differential diagnosis of rheumatic and other autoimmune diseases. So you will see this used in the diagnosis of lupus, rheumatoid arthritis, really any autoimmune diseases. It's going to be part of a larger panel to try and determine what may be going on based on different characteristics and assessments that are presented. A positive ANA does not confirm a disease. There is a such thing as false positives. And then, like I said, the ANA will be positive in patients with lupus, rheumatoid arthritis, and scleroderma. So the anti-D's DNA antibody test, which stands for the anti-double-strand DNA antibody test, it's used to identify and differentiate DNA antibodies found in lupus. It supports the diagnosis, and then you can also test this periodically to see, to gauge the response to therapy. A negative anti-D's DNA antibody test is anything less than 70. If it is greater than 70, then of course it would be positive. HIV testing. So HIV testing, you're primarily going to look at the CD4 cell count. So this monitors the progression of HIV. As HIV progresses, the CD4 cell count will decrease, therefore resulting in a decreased immunity. So remember, patients with HIV, they're going to be immunocompromised, and that's part of the reason. A normal CD4 count is 500 to 1600. Whenever you start to have some immune system problems, some immunodeficiency, you're going to see that decrease to 200 to 499. And then you're going to see that severe immunodeficiency in a CD4 count of less than 200. Also in the same realm, you might see a question regarding the CD4 to CD8 ratio, which can also be used to monitor the progression of HIV. A normal ratio is 2 to 1. So just know if a question asks about a CD4 to CD8 ratio, that normal ratio is 2 to 1. So skin testing. So a lot of you have probably had skin testing performed at your dermatology office or your allergy office. So it's essentially the administration of the allergen into the dermis, the surface of the skin. It can be done via patch, scratch, or intradermally. You do want to educate the patient on the importance of discontinuing any steroids or antihistamine therapy for at least 5 days prior to having any skin testing done. The anti-inflammatory properties of those could skew the results of the testing. So you want to DC those at least 5 days prior. The patient will need to wait in the office at least 30 minutes after to monitor for any signs of anaphylaxis. And of course, you're going to inspect for papules, vesicles, any redness or wheals that would indicate a positive result. So whenever you're reading the results of skin testing, if the reaction or the wheal, they like to call it, if it is less than 0.5 centimeters in diameter, then it is a negative result. However, if it is 0.5 centimeters in diameter or greater, then it is a positive result. Whenever the skin testing is positive, there is a sort of grading scale that goes with that positive result. So it goes from 1+, 2+, 3+, 4+. So remember, if your wheal, your reaction on the skin is less than 0.5 centimeters in diameter, it's negative. If it is 0.5 centimeters or greater, it is positive. Now, to kind of break that positive down, if it is 0.5 centimeters in diameter, it is a 1+ on that grading scale. If it is 1 centimeter in diameter, it's a 2+. If it's 1.5 centimeters in diameter, it's a 3+. And if it's 2 centimeters in diameter, it is a 4+. So just kind of know a positive and a negative skin testing result. Also, it's very important to remember, because you don't know what the patient is going to be allergic to or if they're going to experience an anaphylactic reaction, it's always important to have resuscitation equipment available when skin testing is performed, just so that you can treat any reaction that may come about. So here are your signs and symptoms of anaphylaxis. Very straightforward and very commonly known. So you're going to have itching, redness, some hives, coughing, wheezing. You might have some changes in your vital signs, low blood pressure, tachycardia, cramping, abdominal pain, headache, dizziness. Anaphylaxis, it can be systemic or it can be localized. So you just have to be, when you're performing the skin testing, you have to be prepared for all. Okay, so a latex allergy. Individuals that are at an increased risk for latex allergies, of course, are healthcare workers. They're going to be the ones that are wearing gloves, putting gloves on and off all the time. Also, patients in the hospital are going to be at an increased risk for experiencing this allergy. Symptoms can range from mild contact dermatitis to severe symptoms that affect the airway even. You can be exposed through a cutaneous route, a mucosal, or an aerosol. A cutaneous exposure would be through latex gloves or balloons. Could also be through IV lines or catheters. A mucosal route of exposure is often through condoms that contain latex. It can also be nipples on baby bottles. And the aerosol form can be through powder from the latex gloves in the air, most commonly when someone is pulling those latex gloves out of the box. That powder can get into the air and you can have that reaction from the powder being in the air. So also, fun fact, those that are allergic to fruits, people who are allergic to fruits like kiwi, pineapples, and tropical fruits, they are more likely to have a latex allergy in conjunction with that, which is very interesting. Okay, so immunodeficiency. Of course, the primary concern for a patient with immunodeficiency is infection. So patients that are immunocompromised, they're going to get frequent infections. They also might have a history of alcohol or drug abuse, and they may have a history of long-term use of steroids, which can cause immunodeficiency over time. So anytime you hear or read on an NCLEX question that a patient is immunocompromised, kind of be thinking those things. You're going to be looking out for frequent infections. That's going to be your primary concern. They might have a history of alcohol or drug abuse or a history of long-term use of steroids. You have both congenital or primary immunodeficiency and acquired or secondary immunodeficiency. Autoimmune diseases, there are several different types. Of course, with an autoimmune disease, the body is unable to recognize its own cells as a part of itself, so it attacks its own cells. Examples include lupus, which is very common, scleroderma, you have the pemphigus, and then the polyarthritis nodosa as well. So lupus is one of the more common systemic inflammatory diseases. There is no cure for lupus, but remission is possible. Lupus, very characteristic of lupus and very important to know for the NCLEX, are patients with lupus are going to present with this butterfly rash, which is some redness and erythema of the face. You can also see it on the palms. So definitely associate lupus with a butterfly rash. They may also have anemia, of course, weakness, malaise, fatigue, joint pain. Here comes in that ANA. They will have a positive ANA, an elevated SED rate, and then an elevated C-reactive protein level as well, which are both inflammatory markers. Lupus can result in major organ and system failure, so it affects the connective tissues, and it ends up leading to necrosis and inflammation over time. So when we're thinking about lupus and thinking about different nursing interventions, you do want the patient to avoid exposure to sunlight. You want to monitor for any proteinuria in the urine or the presence of protein in the urine, and monitor the BUN and creatinine levels very frequently for any signs of renal impairment, because lupus often leads to kidney damage. So you want to keep a close eye on that. So remember, lupus, you're going to have a patient with a butterfly rash, and it's very important to monitor the kidneys through BUN and creatinine testing. Okay, scleroderma, it's a chronic connective tissue disease characterized by inflammation, fibrosis, and sclerosis. So it's very similar to lupus. It affects the connective tissue throughout the body. Oftentimes, patients with scleroderma, they're going to have a lot of muscle stiffness, weakness, decreased range of motion. You're going to see they have an inability to perform their ADLs or activities of daily living. On assessment, patients with scleroderma are going to have very taut, tight, shiny skin tissue. It's almost going to look odd because they're going to have no wrinkles in the skin. It's going to be that taut. And then they can also have some dysphagia or difficulty swallowing as well. So some nursing interventions for a patient with scleroderma. You're going to want to encourage very small, frequent meals. Discourage foods that stimulate any gastric secretion. So you want to avoid spicy foods, caffeine, alcohol, anything that is associated with stimulating the gastric secretions. You want to try to avoid that. All right, polyarthritis nodosa is a collagen disease. It's a form of systemic vasculitis that causes inflammation of the arteries and the visceral organs, brain, and skin. So it most commonly affects middle-aged men. Assessment for polyarthritis nodosa, you're going to have bloody diarrhea, severe abdominal pain, and then of course some malaise, weakness, low-grade fever. The treatment for polyarthritis nodosa is very similar to lupus. The cause is unknown and the prognosis is poor. So whenever you see, or if you see the polyarthritis nodosa on the NCLEX, associate that with a poor prognosis. Of course, it's autoimmune, bloody diarrhea, and severe abdominal pain. Okay, so Pemphigus, if I'm pronouncing that right, is a rare autoimmune disease that also occurs in middle to older age. The cause is unknown. Your assessment in patients with this disease, they're going to have very fragile, partial thickness blisters and skin lesions. Associate the pemphigus with Nikolsky's sign, which is separation of the epidermis caused by rubbing the skin. So your skin is very fragile. Of course, you may have some leukocytosis and eosinophilia as well. So just remember the pemphigus, associate that with the Nikolsky sign, very fragile skin and separation of the epidermis caused by any rubbing or impact on the skin. Okay, Goodpasture syndrome. Again, the cause is unknown. It's usually not diagnosed until there's been some significant lung and pulmonary damage that has occurred, leading to other symptoms. But it is an autoimmune disorder in which autoantibodies are made against the glomerular and alveolar basement membranes. It is also very common in males and young adults who smoke. The lungs and kidneys are primarily affected. So if we know that the lungs and kidneys are primarily affected, what are our assessment findings going to be? Going to have dyspnea or shortness of breath, hemoptysis, maybe a little bit of bloody cough, bloody sputum, decreased urine output. You're going to have that fluid retention, so you're going to see edema, weight gain, hypertension, and tachycardia. So whenever you see a question on the NCLEX about Goodpasture syndrome, I want you to automatically think the lungs and the kidneys are affected. If you know that the lungs and the kidneys are the primary organs affected by Goodpasture syndrome, you will be able to formulate an assessment, even if you can't remember the assessment findings, because you'll know if the lungs aren't working, they're going to be short of breath. If the kidneys aren't working, we're going to have low urine output, edema, weight gain, electrolyte imbalances. So associate Goodpasture syndrome with lung and kidney damage. All right, so anybody who lives out in the country, lives in the woods, knows about Lyme's disease. So it's caused from a tick bite, a certain bacteria there that you can see acquired from a tick bite. The assessment, you might have a ring-shaped rash. So anytime you see a circle rash, ring-shaped rash, a patient coming in, the question will likely say that they've recently been hiking or camping in the mountains. Definitely think Lyme's disease. A blood test can be performed. This is diagnosed based on physical exam. A blood test can be performed, but only 4 to 6 weeks after the bite to detect the presence of the disease. So any blood testing before those 4 to 6 weeks is not reliable. Okay. Treatment for Lyme's disease can include antibiotics as well. It just depends on the severity. So there are 3 stages to Lyme's disease: first, second, and third. So that first stage, you're going to have that ring-shaped rash. You're going to have flu-like symptoms. That second stage is going to occur several weeks after the bite. That's when it's going to start affecting the joints. You might have some joint pain and some neurological symptoms. And that third stage is when you might have the development and the progression of arthritis. So Lyme's disease, anytime you think you might have Lyme's disease, it's just very important to go see your primary care provider just so that they can diagnose and treat that early with antibiotics if needed before it becomes systemic. Okay, so AIDS, acquired immunodeficiency syndrome. Of course, it's a viral disease caused by HIV. It destroys your T cells, thus increasing your susceptibility to infection and malignancy. AIDS is characteristic of opportunistic infections. An example of those is the Kaposi sarcoma, which is characterized as purplish red lesions of the internal organs and skin. So a person with AIDS, whenever the HIV has progressed to AIDS, their CD4, their T cell count is less than 200. They're very immunocompromised, so you're going to start seeing the development of opportunistic infections. This is examples of opportunistic infections are yeast infections, cryptococcus, they might have long people with AIDS, they will have long incubation periods, sometimes longer than 10 years before someone even knows that they have HIV or AIDS. Whenever a patient has AIDS or maybe HIV and they haven't been diagnosed yet, they might come in with lymphadenopathy that's been persistent for about 3 months. They might be having diarrhea, fatigue, night sweats, flu-like symptoms. So those are the things a patient's going to come into the clinic. They're going to complain of swollen lymph nodes, diarrhea, fatigue, night sweats, flu-like symptoms, just not feeling well. And that should trigger the primary care provider to test for HIV or AIDS at that time. AIDS treatment, when you're thinking about the treatment for AIDS or HIV, treatment is going to consist of 3 to 4 different medication regimens known as HAART, or highly active antiretroviral therapy, is going to be your treatment. Any medication for HIV or AIDS treatment is going to have various side effects. All of them are probably going to include GI upset, peripheral neuropathy, numbness and tingling in the extremities. You might have headache, diarrhea, hepatomegaly, a little bit of liver issues. The main thing to remember is that a patient with HIV or AIDS is at they're very immunocompromised, and that they're very high risk for the development of opportunistic infections for which either antifungals or antivirals may be used for treatment. All right, guys, that's it.